A very good evening to one and all. Welcome back to the today's session. So today we have our guest speaker, Dr.VM SRUTHY ma'am from Department of OBG, Associate Professor, RVS College, Coimbatore, Tamil Nadu. So we welcome you ma'am. We welcome you all the participants. So today's topic will be regarding polycystic ovarian syndrome and its homeopathy management. So we hope we'll be having a good session. Over to you ma'am. Thank you.
So thank you so much. So good evening all. So we will be discussing about polycystic ovarian syndrome. So why I choose this topic is it's so relevant today because the incidence is increasing day by day. So because of that reason only, I have chosen this topic. Okay. So let's go to our session. Polycystic ovarian syndrome. Actually, it's a syndrome. It is consists of many group of symptoms. Okay, because of that reason only we are calling this as a polycystic ovarian syndrome. As per my knowledge, many UG students are attending this session, so I will discuss all the things in detail. Okay. So actually, this syndrome has got another name that is Stein-Leventhal syndrome. So why is because it is first described by Stein and Leventhal in 1935. Okay, so according to their findings, that those group of persons had obesity, hirsutism, acne, and amenorrhea. So all these complaints were associated with enlarged bilateral polycystic ovaries. So this syndrome is first described by Stein and Leventhal in 1935. So the introduction, it is a heterogeneous multi-system endocrinopathy in women of reproductive age groups. So actually, it will result in chronic anovulation. So that chronic anovulation will result in infertility, irregular breathing, obesity, and hirsutism. So main reason for anovulation in female is PCOS. Okay. So according to Rotterdam definition, according to Rotterdam definition, it should include many symptoms. Okay. So the oligo or anovulation. Oligo means less in number. Anovulation means complete absence of ovulation. So it should include oligo or anovulation or clinical or biochemical signs of hyperandrogenism. That polycystic ovaries. Any of the two should be there in order to diagnose a condition as polycystic ovarian syndrome. Oligo or anovulation, clinical or biochemical signs of hyperandrogenism, and polycystic ovaries. So before diagnosing a condition as polycystic ovarian syndrome, we should exclude other disorders, so which can cause anovulation. So then only we can diagnose a condition as polycystic ovarian syndrome. So incidence, it affects 4 to 6% of women. Then the main reason or main cause nowadays is the change in lifestyle and stress. So this causes anovulation. So most common cause of anovulation nowadays is PCOS. The pathophysiology, we all know the hormones. The main hormones are secreting from hypothalamus. So GnRH will secrete from the hypothalamus and it will act on anterior pituitary. From anterior pituitary, LH and FSH will release and it will act on ovary. Then after that, the ovary will release estrogen, progesterone. So all the physiology you all know. So in PCOS conditions, what happens is due to lifestyle disorders or lifestyle diseases or genetics or due to obesity, it will cause increased GnRH secretion. So the GnRH secretion from hypothalamus will increase. So it has got more affinity towards LH. So what will happen? The increased LH secretion will occur, but at the same time, the FSH level will be normal, or sometimes it will be decreased. So that will lead to the increased LH-FSH ratio. So what will happen? The LH has got action on the theca cells. So this LH will act on the theca cells and the theca cells will produce more androgen. So due to the sedentary lifestyle or lifestyle disorders, the insulin resistance will be there. So it will lead to hyperinsulinemia. So hyperandrogen will be there, and at the same time hyperinsulinemia. Then what will happen is, due to increased LH-FSH ratio, what will happen? The LH will be more. So what will happen? The FSH ratio will be less. So the follicles will not mature properly. So for the proper ovulation, the graphene follicles should be there. So that maturation of the follicle should occur, and one of the important that one of the follicle will become mature graphene follicle. Then only the ovulation will take place. So due to the decreased amount of FSH, what will happen? There won't be any maturation of the follicles, and there will not be any ovulation. So that will lead to the anovulation. So due to the androgen excess, at the same time, what will happen is, because of that increased androgen excess, we can see many changes like hirsutism, acne, alopecia. So we can see many changes due to androgen excess. So hyperandrogenism will cause hirsutism, acne, alopecia, and due to immature follicles, that ovarian follicles will be many, numerous follicles we can see in the ovum, but at the same time there won't be any ovulation. That will lead to anovulations. Then due to absence of ovulation, what will happen? The release of progesterone won't take place. Usually during the time of corpus luteal formation only, the progesterone will release. But due to the absence of ovulation, there will be deficient progesterone. So mostly that cycles will be anovulatory cycles. Estrogen will predominate. So that will lead to increased hyperplasia of the endometrium. That can lead to increased hyperplasia of the endometrium. Okay. Then due to that anovulation bleed, okay, that anovulation bleed will be profuse. Menorrhagia can occur due to anovulations. Okay. Then due to the absence of ovulation, it can lead to subfertility. Okay, these are the main reasons. These are the main pathology we can see during the time of PCOS. So hyperandrogenism will be there. At the same time, that progesterone will be very less. Then at the same time, the estrogen will be more. Then all this can lead to subfertility, anovulation, and androgen-related, hyperandrogen-related diseases like hirsutism, acne, and alopecia. So this is the main thing, hypothalamus and the increased release of GnRH. Then LH FSH ratio will be altered. It will be more than 3. Then compared to FSH, the LH will be more. Because of that, the LH FSH ratio will get altered. Then the main, its action is on the theca cells. It will produce more androgens. So it will act on the skin. Then it can cause hirsutism, acanthosis nigricans. Then increased estrogen. Increased estrogen in the uterus will cause endometrial hyperplasia. Now, at the same time, there will be insulin resistance. So insulin resistance will be there. Then all this can lead to follicular atresia, then amenorrhea, oligomenorrhea. So finally, in PCOS, we can see increased insulin, increased androgens, and increased estrogen. The long-term effect of PCOS is increased estrogen, because usually in normal physiological conditions, androgens will release from the ovary, and these androgens will convert into estrons in the adipose tissues. So due to decreased quantity of sex hormone binding globulins from the liver due to increased insulin. So that increased insulin will reduce the release of sex hormone binding globulins from the liver. What will happen is the free androgens will be there. Okay, so these free androgens will certain quantity will change into estrons. So finally, what will happen is the net outcome will be increased estrogen. So all these can lead to weight gain, irregular periods, unwanted hairs or hair loss, infertility, lack of ovulations. Pathology, finally, the ovaries will increase its size. The size of the ovaries will be 2 to 5 times more than the normal size, and the outer cortex will be pearlish white, grayish white or pearlish white color. So we can see the cyst in the peripheral regions. So we can see multiple cysts. So when we are diagnosing the PCOS, there should be more than 12 numbers of cysts with a 2 to 9 mm size. So mostly it will be located peripherally. So when we are taking the USG, we can see that peripheral arrangement of the cyst as necklace pattern. Then the size as well as the volume will be more. So the ovary will have the more increased volume. So these increase in size can be due to excessive follicles. Then the thicker cells and stromal hyperplasia and capsule will be thickened. So all these are the main reasons for increase in size and increase in volume. So in this slide, you can see how it is arranged. So it is arranged peripherally as a necklace. So we can see the necklace pattern. In the USG, we can see the necklace pattern of the follicle. So what are the changes we can see? Hormonal changes during PCOS. So told you already, because at the final stage, we can see the increased estrogen level can be seen, and LH level is raised. Then FSH level remains normal. So that can be lead to LH FSH ratio, increased levels of LH FSH ratio. Then SHBG level. What is SHBG? The sex hormone binding globulin level fails due to hyperandrogenism or hyperinsulinemia. SHBG is releasing from the liver, sex hormone binding globulin. Then the androgen levels, testosterone and epiandrosterone level rises. Then in certain conditions, we can see the altered thyroid function. Then what is that cytochrome? That is enzyme which converts the androgen. Biologically, it will convert steroids, C25 steroids to C19 sex steroids. So whenever there is increased levels of cytochrome, it can lead to increased DHEA, dihydroepiandrosterone. So what are the main clinical features? We all know it will lead to weight gain, central obesity. The BMI will be more than 30. Then oligomenorrhea or amenorrhea. Oligomenorrhea means that duration of the period will be more. So infrequent menses. So it can lead to, finally sometimes it will be followed by heavy periods. Then it can lead to infertility due to anovulation, pregnancy loss, hyperandrogenism, hirsutism, acne, acanthosis nigricans. Hirsutism, acne, and hair loss, it's mainly due to hyperandrogenism. What is hair and syndrome? Hyperandrogenism, insulin resistance, acanthosis nigricans. Hair, HA stands for hyperandrogenism. IR, insulin resistance, acanthosis nigricans. AN stands for acanthosis nigricans. Hair and syndrome. You can see hair and syndrome in PCOS. So along with all these signs and symptoms, we can see anxiety and depression. So mainly that anxiety can be due to hirsutism, acne, cosmetic causes, and depression. Depression can be due to many menstrual irregularities or infertility or any other weight gain. So all this can lead to anxiety and depression. So this is the main. These are the main features of PCOS: anovulatory and infertility, hirsutism, acne, alopecia. Then hyperinsulinemia can lead to metabolic syndrome. So finally, that person will be more prone for type 2 diabetes mellitus, hypertension, and coronavascular diseases. These are the main symptoms: insulin resistance, obesity, risk of type 2 diabetes mellitus, dyslipidemia, hypertension, irregular menses, hirsutism, acne. At the same time, metabolic syndrome like insulin, obesity, all these things again. So I just want to insist on adolescent PCOS. So what is meant by adolescent period? Adolescent period means it's a transitional phase between childhood and adulthood. So mostly that will range from 10 to 19 years of age. So adolescent PCOS is if PCOS is appearing in adolescent age groups, actually it's very difficult to diagnose because many reasons are there. Because during the time of puberty, initially, at least for 1 year, that cycles will be anovulatory, and increased growth hormones will release during that time. So the anovulatory cycles, and if that patient is overweight and obese, and if that cycle is anovulatory, we can't diagnose that condition as PCOS. Okay, so in case of adolescents, there is certain changes are there in diagnosis. So I want to just insist on that. So anovulation in the first year. So during the first year, mostly that cycles will be anovulatory. So increased insulin resistance will be there due to high release of GH. So then when we are taking the USG also, we can see some changes like polycystic ovarian changes. So but all these will be corresponding with the normal physiological conditions. Okay, normal physiological changes during the time of puberty. So when we are taking the USG itself, we can't diagnose. So we have to diagnose adolescent PCOS clearly. Okay. So PCOS presentations during adolescence, 84% will be overweight, androgen excess, menstrual irregularity, then glucose intolerance or diabetes mellitus. So in case of adolescents, infertility rarely an issue. So proposed diagnostic criteria for PCOS during adolescence age group, 10 to 19 years of age, clinical hyperandrogenism, biological hyperandrogenism, hyperinsulinism, oligomenorrhea or amenorrhea, polycystic ovaries. Hyperandrogenism, we have to confirm biochemically, and menstrual irregularities. So during the time of menarche, there will be some irregularities. So we have to wait for at least 2 years. So at least 2 years post menarche, if there is menstrual irregularities, means we can consider it as that patient will be in the risk of PCOS. Otherwise, we have to neglect it. Then polycystic ovaries include both increase in size and increased number of follicles. So according to new criteria, new guidelines proposed, actually we were following the 2018 guidelines. After that, new one came, that is 2023 International Evidence-Based Guidelines. So according to it, we had to give, for adults only, we have to take USG and anti-Mullerian hormone levels. So in adults itself, instead of ultrasound, we can take anti-Mullerian hormone if there is any difficulties while taking in taking USG. So we can rely on with anti-Mullerian hormone itself in adults. But in adolescents, we can't rely these two investigation procedures, because ultrasound itself, because during normal physiological changes itself showing some PCOM morphological changes. So we can't rely on anti-Mullerian hormone and ultrasounds in adolescents. In adults, we can rely on these two investigations. So along with the features of PCOS, we had to give more importance for metabolic risk factors, cardiovascular disease, sleep apnea, then psychological features of that patient, because all these things are long-term consequences of the PCOS. So we have to give importance for all these factors also: metabolic factors, cardiovascular disease, sleep apnea. It can be due to increased weight gain, very high prevalence of psychological features. Then during pregnancy also, it can lead to adverse outcomes. So we have to give more importance for these things also. Then if when we are doing some investigations and it is not meeting the diagnostic criteria, but that person is having the features of PCOS, means we can include that person under increased risk group. So post menarche, if that within after the 8 years, if that person is having the features of PCOS, but it is not meeting the diagnostic criteria, means we can include that person as increased risk groups. So before starting any type of therapy, we have to we have to rely on such features. Okay, so those with if that person is having that features, and if that person is weight gain, then we have to include that person as increased risk group. So hyperandrogenism. So hyperandrogenism, how we will assess? Because mainly hyperandrogenism is causing hirsutism, acne. Then so before before starting any treatment, we have to confirm it as hyperandrogenism. How we will do is by through the signs and symptoms. So hirsutism will be there, and then acne will be there, and that patient is not unresponsive to the topical therapy. And if there is increased levels of total or free testosterone levels. So normal, when we can say that the testosterone level is high, more than 55 nanogram per deciliter. Then acne, if there is more than 10 facial lesions in early puberty or inflammatory acne during perimenarchal years. Then if even after giving the topical treatment, if that if they are not getting any cure, means we can include that under inflammatory acne or that comedonal acne. This is a picture of severe acne. So we are using modified Ferriman-Galway score for assessing the hirsutism, scoring the hirsutism. So we can give marks according to the distribution of the hairs. So hirsutism, we can isolate a mild hirsutism, that will score 9 to 15, moderate 16 to 25, then high severe hirsutism if it is more than 25. So if a patient is if a woman is taking hormonal contraception methods, then we should not do the test for hyperandrogenism. So we have to ask the patient to stop the medicines for 3 months, and after that we can do the test. So this is the clear-cut support for the hyperandrogenism, elevation of total or free testosterone. So if the testosterone levels are normal, what we have to do next is we have to take other test for androstenedione or dehydroepiandrosterone sulfate, because in order to exclude other causes, we have to do this test. Okay, so sometimes it can be seen in androgen secreting adrenal tumors. So there will be hirsutism, acne, and also in order to rule out other causes. And if the testosterone levels are normal, we can do the test for aldosterone and dehydroepiandrosterone sulfate test. So investigations not recommended in adolescent age group, 10 to 19 years of age, is pelvic USG and anti-Mullerian hormone. But we can do USG if there is any symptoms suggestive of virilizing tumors. If there is any rapid progression or clitoromegaly, pelvic mass, then total testosterone levels, if it is more than 200 nanogram per deciliter, then any disorders in the sex or sexual development. So in such cases, we can suggest USG. So along with all of the findings, anxiety and depressive symptoms should be routinely screened in all adolescents and women. Anxiety and depression. If the screening results are positive, further evaluation and referral for assessment and treatment. High prevalence of moderate to severe anxiety and depressive symptoms in PCOS in adults, and a likely increased prevalence in adolescents. So emotional well-being is very, very important when we are treating the PCOS. So we have to give more importance to this also. So anxiety and depressive symptoms should be assessed. So if they are having such symptoms, we have to give the psychological interventions. So if the patient is having any behavioral problems or any abnormal eating patterns, then if that patient is very anxious or depressed due to the acne, hirsutism, and obesity, so we have to give the proper interventions. What are the main consequences of PCOS? The short-term consequences we already discussed: obesity, infertility, irregular menses, abnormal lipid levels, hirsutism, acne, androgenic alopecia, glucose intolerance, acanthosis nigricans. Acanthosis nigricans means blackish discolorations. So long-term consequences: diabetes, endometrial cancer due to increased estrogen in cardiovascular diseases. So main things we have to differentiate is because it can be due to that dysfunctions in the menses or anovulation can be due to many other things like thyroid diseases. So we have to rule out hyperthyroidism, hypothyroidism, then hyperprolactinemia, then hypogonadotropic hypogonadism. Then hyperandrogenism can be due to any androgen secreting ovarian tumors, then adrenal tumors, Cushing syndrome. Then so we have to rule out all these things. So these are the differential diagnoses of oligo-ovulation, anovulation, and hyperandrogenism. So thyroid diseases we have to rule out hyperprolactinemia, then hypergonadotropic hypogonadism, then androgen secreting ovarian tumors and adrenal tumors, then Cushing syndromes. So in adults, we have to move on with the investigation. So in adults, the main investigations, USG, ultrasonography. So we already discussed, we can see many follicles in the peripheral region. So there should be more than 12 or more follicles with a 2 to 9 mm size. Then anti-Mullerian hormone. What is anti-Mullerian hormones? Actually, it will release during the maturation of the follicles. So it can be used as a diagnostic tool to identify polycystic ovarian morphology or hyperandrogenism. So high AMH level correlates with higher andral follicular count. So increased AMH denotes the increased number of follicles. So actually that AMH, we can't rely on its correct value because there is no cutoff value. So 4 nanogram per ml or higher is considered high. Then management. How we can manage PCOS. So our treatment aim should be to regulate the menses, to higher androgen. We have to treat the higher hyperandrogenic conditions. Then we have to improve the metabolic status, then lifestyle issues. Then if there is any comorbidities, we have to address that also. So irregular menses, how we will manage? Because according to the pharmacologies, we have to give the combined oral contraceptives because it consists of both estrogen and progesterone. So when we are giving progesterone, it will reduce the luteinizing hormone. Then estrogen will increase the release of sex hormone binding globulins from the liver. So it will reduce the quantity of testosterone. It will reduce the androgen levels. So irregular menses we can control by giving combined oral contraceptive pills. Then hirsutism and any conditions which is related with the hyperandrogenism, we can give the medicines which reduces the androgens. Then glucose intolerance or diabetes and obesity, metabolic syndrome, metformin. They used to give the metformin. So we can divide the management into, classify the management into non-pharmacological management, pharmacological as well as surgical management. Non-pharmacological therapy means we have to improve the lifestyle, weight loss. So weight loss is very important because when we are reducing the weight, then that itself clears the hormone levels. So it will increase the secretion of sex hormone binding globulin from the liver, and then it will reduce the testosterone level, free testosterone levels. So insulin level also reduced by reducing the weight. So weight loss programs are very important in the case of PCOS conditions. Then lifestyle, we had to reduce the cessation of the smoking because all this will increase the androgen levels. Then importance of diet. So in lifestyle management, when we are targeting, when we are focusing on the weight loss, definitely we have to focus the diet plan. So dietary energy, dietary intake, the nature of the food, everything is important. So along with the exercise and all, we have to focus on the diet also. So we have to include more vegetables, fruits, whole grains, healthy protein. Then we have to drink more water. We have to include healthy oils in our diet. So these are the main foods we have to include in PCOS diet. Leafy greens, because we have to include those type of food which reduces the inflammations, then which will balance our hormones, and those foods which will reduce the insulin sensitivity, then metabolism, which increases our metabolism. So like that, we have to include all type of food which are helping to reduce insulin, then stabilize the blood sugar or blood glucose level, which balances our hormones, which reduces our inflammations and all. So we can add more herbs, spices, fermented foods, because nowadays many researches are going on that fermented foods which will promote the gut health. Okay, so because of that imbalance or that microorganism also causes, it also becomes one of the important causes for the PCOS. So we have to improve the gut health also while treating the PCOS. So we have to include yogurt, like curd, yogurt, then we have to include low glycemic fruits. So lifestyle modification is very important, and weight reduction programs we have to include. Then we have to manage type 2 diabetes. Then we had to regulate our menstruation and ovulation. So this should be the aim of a physician. So we have to reduce insulin LH level, increase SHBG, decrease free estrogens, improve menstrual function, reduce hirsutism and acne, lower testosterone levels. So we already discussed about the oral contraceptive pills, because all these things will help in regulating the hormones. So luteinizing hormone should be reduced, and we have to reduce the testosterone levels and androgens. All the androgens should be reduced. So the role of estrogen. Then clomiphene. What's the role of clomiphene? It will induce the ovulations. So in if there is chronic anovulations, we can combine clomiphene or metformin. We can give combinedly. Then progesterones or oral contraceptive pills. Then if there is no, because in anovulatory cycles there won't be any corpus luteal formation, so that will lead to no progesterone. So irregular bleeding will be there because of the presence of estrogen. So that hormone, main dominant hormone will be estrogen. So it will cause irregular bleeding. So when we are giving combined oral contraceptive pills, then progesterone will act on the will come into the play. So it will regulate the bleeding. So if we are using metformin, it will improve the fertility rate, and it can be used as insulin sensitizer. Case of PCOS, so we can adopt surgery when the medical therapy fails. Hyperstimulation, if there is any hyperstimulation and infertility, then any previous pregnancy losses, we can opt for surgery. So mainly laparoscopic drilling or puncture. When we are doing the drilling and all, so we should not drill more than 4 cysts. Laparoscopic ovarian drilling and bariatric surgery. Bariatric surgery if that patient is having BMI more than 30-35. So what are the disadvantages of surgery? It will cause adhesions. It can cause post-operative complications. So it can cause adhesions. Then premature ovarian failure due to destruction of ovarian tissue if cautery is used. For this reason, many now prefer simple puncture of the cyst. So post-operative complications will be more. So because of, in order to avoid that, only simple puncture of the cyst is now preferred. So even after doing the surgery, we had to give proper counseling because it can recur at any time. So we had to give the proper counseling. Then the diabetes, long-term diabetes and endometrial cancer may develop in PCOS patients because of increased insulin resistance and increased quantity of estrogen. So actually, we can't prevent that because if the lifestyle, if we are maintaining that proper lifestyle, then we can avoid to some extent. Obesity and the lifestyle changes are recommended in order to prevent it. Then we will move on with the homeopathic management. So important medicines. So in this repertoire we can see female genitalia, sex or female sex, tumors, ovarian cysts. The main medicines are Epis, Oromo, Natronatum, Bovista, Bufo, colocin, iodine, calibro, lactasis, palladium, phosphorus, platinum, restox. So right-sided complaints, right-sided ovarian affection, epis, bell, lyco, palladium, and podophylla. So left-sided calibi, lactasis, naja, palladium, phosphorus, platina, and thuja. In Murphy repertoire also we can see the important ones are epis, thuja, lactasis, then lyco. So in this repertoire we can see the epis is coming under both left and right affections. Okay. Asafoetida, aurum, bell, Cantharis, carboanimalis, china, conium, calica, lactasis, platina, Chaffisagria. So sides. So mostly we will divide the medicines according to the side of affection, right ovarian affections and left ovarian affections. So in right side, we already discussed many medicines. So we have to discuss which remedy is this. Helpful in curing cystic conditions of the ovaries, endometrium, and helps reduce water retention in the body and body weight as well, be it in inches or kilograms. All the cystic conditions of the ovaries, endometrium, and helps reduce water retentions in the body. Edema, and we are giving this medicine for edema conditions and all. Which medicine? Epis mellifica. It's one of the important remedy in treating PCOS conditions. Next medicine, that indignation causes vomiting, diarrhea, cough, pain abdomen, irritability of bladder, pain in heart, menses suppressed, voice lost. Next clues. Dwells on past insult, weeping from past insult, hypochondriasis, hysterical, constitution. Patient usually young woman, very much weak, debilitated, guilty, craves tobacco, having what? Unhealthy skin, nervous, melancholic temperament, chilly patient, Sora psychosis in background. Medicine? Staphysagria. Haughty, next medicine. Haughty, rudeness, arrogant, headache, objects appear small, frequent menses, sadness, inflammation of ovary, infertility, platina. So another medicine, another group of medicines, calcareous calm. So calcareous calm is very efficacious because when the constitution of that patient matches with the symptoms. So we can give calcareous calm when we are getting the correct symptoms, when the patient symptoms matches with the constitution of the constitution of the patient matches with the local symptoms. So the sepia, next one is sepia, one of the important medicines in female complaints. So there will be ball-like sensation in the inner part, bearing down pain. Then pelvic orgasm will seem relaxed. Then menses will be sometimes late and scanty, or in some others it will be early and profuse. So in all type of irregularity of menses, we can think of sepia. So one of the important homeopathic remedies in treating PCOS with bearing down pains. So calcareous calm, then sepia. Then phosphorus. So we can see in some persons, some persons will be very lean. Even though they are diagnosed with PCOS, that persons will be lean. So in such patients, actually that metabolic syndrome will be very less. So they won't have that symptoms of metabolic syndrome. So we can think of phosphorus in such patients. That patient will be very sensitive, intelligent, long, slender person. And if they are having PCOS with the stitching pains in uterine region, we can think of phosphorus. So the menses will be early, scanty, and long standing. Calcareous force. So like phosphorus, we can think of calcareous force in lean persons. PCOS in lean persons. The females will be lean, thin, anemic with the weak bones, too early, excessive, and bright menses. Then lycopodium, a constitutional important constitutional remedy for all the complaints. So if that lycopodium is also important medicine, efficacious remedy in case of patients with the loss of confidence, then marked emaciation, particularly of upper body part. So we can think of lycopodium. Actually, it will give good results if constitutionally, if it matches with the symptoms of that particular patient. Then corneum. Corneum is a remedy for PCOS that are caused by suppression of unsatisfied sexual desire. Then it is suitable for PCOS with dysmenorrhea and pain in thighs. So corneum is important medicine in all the glandular affections and cystic conditions. It is very important medicine. Buforana. Buforana is a palliative remedy of PCOS for controlling pain. Then the symptoms will include menorrhagia and metrorrhagia. Metrorrhagia means intermenstrual menses. So menorrhagia as well as metrorrhagia we can give Buforana. It is acting as a palliative remedy for pain. Then carcinosin. So whenever we are suspecting any malignant changes, we can think of carcinosin. So it's an ozone and it is given in all cases of malignant outgrowth. So if that patient is having any family history or we are suspecting any malignant changes, so we can use carcinosin as an intercurrent remedy. So in the ovarian diseases, we have to think of Epis, Aurum mood natronatum, Aurum iodine, Candaris. Candaris, it is very, it will have that patients will have very sensitiveness towards the pain, then urinary, along with the urinary complaints. Then Carbo animalis. So it is useful in Crophilus constitution, right ovary. Mainly it will affect the right ovary. So it will feel like a heavy ball. So in all type of ovarian cysts, we can think of Carbo animalis if there is any heaviness and if it is affecting all other glands. So scrophulous constitutions is marked in Carbo animalis. Simicifiga. Simicifiga amenorrhea with the pain in the ovarian region. Then that pain will radiate towards the surface of thighs. So along with such pain, that patient will have backache and other complaints. So cornea, when the patient is having suppressed menses and sterility. Euphorina. Euphorina is very good medicines for ovarian cysts. So these are the important medicines in ovarian diseases. So euphorina, when we are giving, we can improve the ovulation and the quality and quantity of eggs. So along with the euphorina, we can think of acid force also. So euphorina and acid force are very good in improving the ovulation and quality and quantity of eggs. Insulinum, because we already discussed about the hyperinsulinemia condition in PCOS. So we can think of insulinum, an excellent medicine for managing insulin levels in PCOS patients. So in conclusion, every woman suffering from PCOS or ovarian cysts presents with different set of symptoms. So we have to analyze each case in different perspective. So we can't give specific medicines, but we have to think of the whole case. We have to evaluate each case separately and we have to select a medicine according to their constitution and all. So the patient with PCOS, if young, are mostly concerned about their personal appearance and irregular menses. So the result of the presented case of ovarian disease is encouraging symptomatic improvement and disappearance of ovarian pathology. But these cases requires long-term follow-ups with constant reassurance to patient to prevent dropout. So in PCOS conditions, along with the lifestyle management, diet, and medicine, we have to give counseling also because we have to give constant reassurance to the patient. So whether it is treatment of hormonal imbalance or regulating menstrual cycles, seeking relief from the side effects of prescribed medication, or support in dealing with the stress and frustration associated with complications or the emotional turmoil of being diagnosed with PCOS, ovarian cyst, homeopathy helps to restore health on both physical and emotional plane. So the homeopathic medicines are cost effective, gentle and free from any side effects. Various studies conducted till date establish a positive role in treating ovarian diseases. The need of the hour are well documented cases on ovarian diseases to achieve the target of evidence-based medicine for homeopathy. So thank you. Thank you for listening and active participation. Hello.
Thank you, ma'am. Thank you so much for the wonderful session. It was quite enlightening, and you have explained everything in a such a detailed way that with the right from the introduction right to the homeopathy medicine, what to be used, how to be used, when to be used. So thank you, ma'am. Any questions from the participants? They can comment in the comment box so that ma'am will be answering. Yeah.
Any questions?
What about the relation to the PCOD and mental plane, ma'am, in a woman?
Pardon? The question is not clear. Can you please repeat?
Uh, yes, ma'am.
Uh,
Actually, is there any relation such that if the woman is mentally strained, so in many of the families, women are obviously mentally strained and they will take the everything to the heart. How come that? Is there any relation between that mental stress and
yes,
PCOD, ma'am?
yes, yes, because the stress is also acting a major factor in the development of PCOS, because nowadays many researches are going on because we are giving more emphasis on the mental symptoms nowadays, right? So nowadays we have to mainly focus on the stress also, because the stress is also acting as one of the main important factor for the PCOS developments, because it will lead to lifestyle changes. So they will that will lead to behavioral problems, then that will lead to eating disorders. So that stress can cause many psychological effects. So that will lead to the development of uh, PCOS, because it will make some changes in their lifestyle. Stress. So that's also acting as main important factor nowadays. So we have to consider that factor also. Stress.
Mhm. Thank you, ma'am. There are a couple of questions, ma'am, from a participant.
Okay.
They are asking regarding any clinical cases that have been treated by you regarding to this PCOD, ma'am.
Yes, yes, yes. Because recently, actually, when we are treating PCOS, we have to, the main, how I am treating is I will be giving constitutional medicines. Okay. So, but if that patient is having any ovulation complaints, if an ovulation, so I used to give oforinum or folliculinum according to their conditions, because this oforinum and all will help us to stimulate the ovary. So I used to prescribe along with the constitutional medicine oforinum.
Yes,
Three,
ma'am. Thank you so
3x.
much, ma'am. Oh, okay, ma'am. How many days, ma'am?
What?
Regarding the days, ma'am, depending upon the severity of the disease, ma'am.
No,
Days to be
actually
prescribed.
we have to monitor the ovulations, because we have to do the ovulation test. So follicular study and ovulation test we have to conduct in such patients. Mostly they will have that complaints of infertility and all. So we have to focus on the ovulation. So we have to do the ovulation test. Then in order to if that patient is teenage girls and all, then they will not be concerned about the fertility. Okay, but a married woman will be concerned about their infertility. So we have to do the ovulation test along with the treatment. So regular ovulatory test should be done.
Okay, ma'am.
Follicular study.
Uh,
Uh, yes.
yes, ma'am. Thank you so much, ma'am. And the next question is they're asking your style of prescription for PCOS, ma'am.
Sign up.
Your style of prescription, ma'am.
Style of
Prescription for
prescription. PCOS
the
conditions.
PCOS, ma'am. Huh.
Okay. Actually, it's up to the, we have to consider the age of the patient also. In adolescent age groups, actually, they will be very concerned about their acne. They'll be very concerned about their weight and hair loss and all. So we have to focus on such things also. We have to give proper instructions regarding their diet. We have to give proper instructions their exercise and all. So when we are giving some instructions regarding the weight loss and all, that itself causes regular hormone secretions. So we have to give proper management, okay, lifestyle management along with our treatment, along with our medicines. So in case of adults, usually menstrual irregularities will be there. So they will be very concerned about that. Okay. So compared to adolescents, they will be least concerned about this hair loss and acne and all, but they will be more concerned about their menses. So we have to correct it. So we have to give medicines according to their constitution, and we have to do, if they are concerned about their fertility, if they're planning for baby, then we have to do the ovulation test, and we have to correct that also. Mostly the adults will be coming with the irregular menses, oligomenorrhea or amenorrhea. So induction of menses should be the prime concern. Okay, so menses, we have to regulate the menses first. Okay, along with the diet, lifestyle, exercise and all, weight reduction, we have to give the medicines, and we have to induce menses in such patients.
Thank you so much, ma'am. Yes, ma'am. Thank you so much for clearance, ma'am. Any other questions from the participants? They can comment in the comment box. So I hope they were clear with the rest of the topic, ma'am.
Okay.
So we will conclude the session, ma'am. Then, thank you so much, ma'am. Thank you so much for enlightening us with the valuable knowledge regarding the PCOS. And thank you so much, all the participants, for your active participation. So tomorrow we'll be get back with one more session by Dr. Pranav Shah, sir. So get ready for the session at 7:30 p.m. tomorrow. So thank you all. Thank you so much. So thank you, ma'am. Thank you all the participants.
Thank you, AIHSAYA, for giving me a platform like this, and thank you so much.
Thank you, ma'am. Yes.